Hey guys, I am Duncan. I'm a third year. I've worked with many of you. And yeah, I'm excited to talk about hyponatremia today. To particularly do like a little bit of a deeper dive than we maybe typically get, because I think it shows some of the interesting physiology, and the kidneys are amazing. And so hopefully we can have a little bit more of an appreciation for it. Looking at the chat, it seems like Mac is also a kidney enthusiast. So I'm glad that there are some more of us out there. That's really my only disclosure, is that I genuinely like hyponatremia, and I think it's really interesting. And part of the reason I wanted to talk about it, because I think it's like a very classically intimidating topic in internal medicine. I pulled these from, I'm not sure if you guys are on Med Twitter, but it's very funny, and you actually get a lot of really sort of like up-to-date information from it. But I feel like hyponatremia at some point in your training is very intimidating. And so I think it's a good topic to review and make sure that we have like a practiced algorithm and feel like that we have a sense for a patient who comes in and is hyponatremic, like we should be able to get to like a fairly good understanding of what's driving the physiology. And so that's part of the goal for today. So learning objectives, we're going to review an ADH-based algorithm for hyponatremia. A lot of this is sort of what's classically taught here at UW, so this may be review, but I think good to go over at the start. And then we're going to spend a little bit more time on what I sort of term like the ADH-independent forms of hyponatremia. So classic forms of hyponatremia where ADH, antidiuretic hormone, is not activated, both because I think it has really interesting physiology that helps us understand overall what's going on with hyponatremia, and because these patients are high risk for overcorrection. It's really important for us to recognize this. And then we're going to use some of that physiology to see how we can apply that to practical like SIADH management in the hospital, which I know is something that we have all struggled with at some point while caring for our patients. And then lastly, just like make sure that we're all on the same page in terms of identifying like patients who are at high risk for overcorrection, because that is one of our like biggest tasks as internists, is to make sure that we don't overcorrect someone and put them at risk for osmotic demyelination. So before I jump right into the algorithm, just wanted to quickly review the symptoms of hyponatremia. And I think what has always struck me about these symptoms is how kind of like vague and wide-ranging they can be. So anywhere from just like fatigue, maybe a little bit of nausea, all the way to seizures, like coma and death. And really, this confused me for the longest time, but when it comes down to it, all of these symptoms, and the reason that we really care about like hyponatremia in the first place, is that hyponatremia is really just a stand-in for hypotonicity or low serum tonicity, which in turn causes cerebral edema. And that's where we get all of these very vague symptoms from that can, again, range from something that's pretty mild to actually life-threatening. So like when we are talking about hyponatremia, really, we are just talking about serum hypotonicity, and that's why we care about it. Thanks, Mac. Yeah, me too. Me too when I'm on call. Okay, so jumping into the algorithm. So this is a common one. It's going to be based on sort of ADH rather than like initial volume assessment, which you will sometimes see in like online algorithms. I like this algorithm because you can sort of ask like 3 fundamental questions about a patient. Each of those questions has a corresponding test. And like if you can sort of work through this systematically, like you can understand most cases of hyponatremia for your patient. And again, because like serum hypotonicity is what we care about with hyponatremia, like the very first question that we should ask is like, do we care about this low sodium? And the test that we run is the serum osm. So what is the actual serum tonicity? And you guys, I'm sure, have classically seen there are many times when the sodium is low, maybe the sodium's like 128 or so, but the sugars are 600. And so that's actually just like a dilutional hyponatremia. Like the sodium is actually low. The glucose that's in the extracellular space has pulled out water. That water has diluted out the sodium. So it's not like it's a false low reading of the sodium, but we just don't care because the serum osms themselves are normal. So again, we're not at the risk for cerebral edema and the other sort of like complications of hyponatremia that we care about. And then pseudo hyponatremia is a subtly different sort of phenomenon. And this is actually an issue with the lab test itself. So the serum, or like the serum sodium levels, are actually normal, but because of like high triglycerides, high cholesterol, sometimes a paraproteinemia, like the lab itself just like doesn't accurately test the sodium. So this is sort of like when someone comes in, it is worth checking a serum osms just to make sure that we actually are dealing with hypotonic hyponatremia, which is again the reason that we care about hyponatremia. So we're now at this part of the algorithm, which again, yes, it is like a hypotonic serum, so we do care about this low sodium. And this is where sort of I like starting with ADH and sort of asking the next question of, is ADH activated? Because again, ADH is sort of the driving hormone that regulates our serum tonicity. ADH is antidiuretic hormone. It acts on the collecting duct of the nephron, and it inserts aquaporin channels that sort of resorb back free water. So when ADH is activated, the urine becomes concentrated, we resorb back free water, and we can dilute out our sodium. And so this is how the body maintains its serum tonicity. And so the tests that we run to see if ADH is activated are the urine osms. And so we will briefly just mention that sort of when you check urine osms, if the urine osms are low, this is actually a really interesting set of conditions that we're going to spend quite a bit of time talking about later. But essentially, ADH isn't activated, so the kidneys are doing their very best to try and get rid of all the free water that's being ingested, but they can't for whatever reason. And we'll come back to this in a little bit. But I'd say, like, obviously the things that we most commonly see in the hospital are where, yes, like ADH is activated, we are seeing a concentrated urine with the urine osms usually above 200, even 300. You'll see obviously up to the 500s. Even I've seen like in 1,000 in the hospital. So most of the time for our patients in the hospital, ADH will be activated. And then the question that we have to ask next is like, is this appropriate? And like, does this make sense? And really what we're getting at there is like, is this a low perfusion state for the body? Because again, like ADH, its primary role here is to regulate serum tonicity. But if the body is really struggling with perfusion, the sort of like backup measure is to sort of retain more free water. We're going to sort of sacrifice a change in our serum tonicity and have like a low serum tonicity in exchange for having a greater effective plasma volume and increased perfusion. And so the question that we ask, like, is this for like identifying if this is a low perfusion state, is the urine sodium. And because that is getting at the renin-angiotensin-aldosterone system. So the RAS system should be our body's primary mechanism of maintaining volume and perfusion status, like aldosterone resorbs sodium from the distal convoluted tubule and the collecting duct, just like aquaporin and ADH does for water. And so like if we're in a low perfusion state, RAS should be activated. And so that's why we look at a urine sodium, because if the urine sodium is low, that's an indication that like, yes, aldosterone is active, the RAS system is active. And so ADH in some ways is being activated appropriately because it's a body's defense mechanism against like an ineffective plasma volume that's leading to poor perfusion. And sorry, there's a question here. What if we just change sodium to osms in the chemistry panel if it's what we, oh yeah, that's a great question, Lauren. I think it like comes down to like the speed at which the test comes back. And like serum osms, as you guys have probably seen, it can actually take a while to come back. And so we use sodium because again, it's like a good stand-in for most of the time. It will give us a sense for what's going on with the serum osms. Great question. But yeah, so going back, we are in this state here at the bottom where the urine sodium is low, so the RAS system is activated. ADH like seems to be appropriately activated as a backup mechanism for perfusion in this setting. And so these are sort of like the classic conditions that we typically see in the hospital. So like we will see a lot of like hypovolemic hyponatremia, and then also like other poor perfusion states like heart failure, cirrhosis, sometimes even with nephrotic syndrome. And this is like in part why I like going through like an ADH-based algorithm rather than a volume status, because we are classically like, it's really difficult to accurately assess someone's volume status despite sort of what we might like to believe about our skills. And so if you like start right at the top of like trying to see what a patient's volume status is and then going through an algorithm based on that, I think you're a little bit more prone to error. Whereas the nice thing about this, like in this sort of far right corner here, like it's pretty clear if someone is like truly dry and hypovolemic versus like, oh gosh, they are so congested from heart failure that they are in a poor perfusion state. And so usually we're able to make that distinction more reliably than like, oh gosh, is this person like dry? Are they euvolemic? Is this person euvolemic to maybe a little bit volume up? And so that's why I think this is helpful. And this is also gets at why hyponatremia is such a poor prognostic indicator in conditions like heart failure and cirrhosis, because it's an indicator that despite being like total volume, total body volume up, that you are still in a state of like hypoperfusion. And so that's why like sodium factors heavily in the MELD score, and it is also prognostic in heart failure. And that's why we care about it when someone's coming in with a heart failure admission. I'll just pause quickly for any questions so far. I know this is a lot of sort of review and what we typically go through. Cool. Jordan, great question. It's one of the frustrating things. No, like the cutoffs are really dependent. So you'll check a couple of different algorithms. Like for example, for urine osm, some people will say 200, some people will say 300. Some people like put it at a very random cutoff of like 280 is something that I've seen. The tricky part is like based on the health of the kidney. The kidney's like ability to dilute urine can change a little bit. So for example, in someone who has CKD, they might not be able to dilute their urine as effectively as someone with normal kidney function. And so like there will often be times where you're sort of in a tweener kind of state, and we're actually going to go over that. Like in particular with the urine sodium, I feel like the urine sodium can be a little bit all over the place. But there are some like pearls and like tips that we can use to sort of like help differentiate between those patients. But that's a really good question. So yeah, going back, so again, we are at this point in algorithm where ADH is activated, but now we're at this interesting point where like it doesn't seem like RAS is activated. So maybe this isn't a low perfusion state. And again, our clue here would be a high urine sodium. So the kidneys aren't caring about pulling back that sodium and hanging on to volume. So this doesn't seem like this is a backup mechanism for perfusion. And this is where we fall into this category where like obviously SIADH, syndrome of inappropriate ADH release, is appropriately named because it doesn't really make sense why ADH is activated in this setting. And this is also where adrenal insufficiency will fall. A couple of reasons for adrenal insufficiency will present like this in terms of the labs. Adrenal insufficiency can obviously be a low perfusion state, but because aldosterone isn't available in the setting of adrenal insufficiency, the adrenal glands aren't producing aldosterone, the kidneys can't resorb sodium. And so like the urine sodium will be high despite the fact that they are at a low perfusion state. So just be aware that adrenal insufficiency, cerebral salt wasting with high, yeah, totally. That also sort of is a rarer one that will like fall in this category here too. And then hypothyroidism, like you will see on all these algorithms, I have looked and like tried to identify a mechanism that can sort of reliably relate hypothyroidism to like hyponatremia. And it seems like there's really no consensus as to whether or not this is really a thing that we should care about or if there's a clear mechanism. Like clearly for people who are in mixed edema coma, like you can have hyponatremia as one of the like presenting characteristics, but like if you check a TSH and it's 15, like it's not really going to tell you all that much about what is driving the patient's low sodium. And then in terms of labs, like it is reasonable if adrenal insufficiency is on your differential. This is when like an AM cortisol can be useful. And so, yeah, like this sort of bottom corner of the algorithm, I feel like this is where we spend so much of our time and thought process in the hospital on, because again, sometimes it is tricky. Like your urine sodium, like maybe is kind of in between, like maybe it's right around 20. It's not really leading you one direction or the other. Maybe the patient's been on diuretics. And so can we trust the urine sodium? And as we'll talk about, SIADH has like a million different things that can cause it. And so oftentimes we're stuck here and trying to waffle between these two sort of like distinct low perfusion, like normal perfusion states. And so just like a couple of like pearls that can maybe help in this setting, because again, we are often stuck here and we spend a lot of time talking on rounds about it. Serum uric acid, like if you're stuck between a low perfusion state versus SIADH, can be very helpful. For whatever reason in SIADH, like uric acid levels like drop pretty significantly. And so you'll typically see levels below 4 milligrams per deciliter. Not exactly clear what the mechanism is there, but it's fairly reliable. And then you can also use like additional markers of like poor renal perfusion. So like a FeNA or a Fe urea if the patient's on diuretics. And then also just like looking at the BUN and creatinine and the ratio. In SIADH, oftentimes we will have like a very low BUN and a relatively low creatinine. So again, just looking at all of like our standard things for identifying like a pre-renal state, like imagine this was an AKI, we're trying to identify if there's poor perfusion going on to the kidneys, and this can be helpful for identifying between these two. And Rima has both DI and SIADH. Yikes. Yeah, that sounds really difficult to interpret. And again, I will pause here because again, this is like a that's a good idea, Mac. I will pause here, see if there's any questions. I know this is like sort of our standard algorithm. Maybe some of these pearls on the left are useful. But next we're about to dive into like the ADH independent causes. So like the primary polydipsia, tea and toast, and beer potomania. But before we do that, just wanted to pause. All right, we're gonna keep going. Okay, so again, we're gonna look at these sort of ADH independent causes next. I think they are super, super interesting. Because it's, again, it's a situation where the kidneys are trying to do their very best and they're trying to excrete free water, but they still aren't able to maintain serum tonicity. And fundamentally, what's going on is that there's an insufficient ratio of solute ingestion to free water consumption. And so just like breaking down the basics, like what are solutes? Technically, solutes are anything that dissolve in a solvent and create a solution. But like from a realistic purposes, like solutes are things like ions. So like when we take in salt, we can use that sodium chloride in the urine to either dilute or concentrate urine. Amino acids, so like protein intake is like a really important source of like solute load for our kidneys, either because like the amino acids themselves end up in the urine or because eventually the proteins get broken down into urea and that obviously comes out in our urine and can be used as a solvent. And then like things like glucose, like again, sometimes if the glucose levels are high enough, it'll end up in the urine and that can act as a solvent. And this is why SGLT2 inhibitors might actually be useful in some cases of SIADH, which we'll get into in a little bit. But, okay, so now we're gonna go into some math and some algebra. So bear with me here. So we're gonna look first at like, for an average person eating like an average American diet, like what sort of is the total daily solute load for the kidneys? And so here we're looking at a 70 kilogram sort of like average sized patient. Let's assume they're eating kind of a standard American diet of like salt, protein, fats, like things that can give our kidney solute to work with. Like with that, we end up with about 700 milliosms of like a typical solute load to the kidneys. And then with this solute load, that's essentially what the kidneys have to work with to maintain their serum tonicity throughout the day. So if you think about like what sort of the maximal dilutional capabilities and the maximal concentration capabilities of the kidneys are, it's pretty amazing. Like the kidneys can dilute urine to sort of a maximum dilution of about 50 milliosms per liter, or get all the way as concentrated as 1200 milliosms per liter. So that's a 24-fold difference, which is pretty amazing. And then if we do a little bit of algebra here on the bottom, and again, concentration is milliosms per liter. If we rearrange to sort of calculate how much free water that means that our kidneys can like safely ingest throughout the day, we just do a little bit of sort of rearranging and we get that the free water is the solute divided by the concentration. And so when we pop this in here, when we are maximally dilute, like with that 700 milliosm load, we can ingest 14 liters of free water and still maintain serum tonicity. And conversely, if we maximally concentrate our urine, like we can ingest as little as 0.6 liters of free water and still maintain our serum tonicity. So that's how like impressive and amazing the kidneys are. And this is why like, it doesn't really matter all that much, like how many cups of water you drink. The kidneys, for the most part, like should be able to handle it and they'll be able to maintain your serum tonicity. Now, in like these ADH independent causes of hyponatremia, like something is going on over here. And like we are still in this point where like the kidneys are maximally diluting their urine, and yet we are still ingesting too much free water. And so the first cause of this is just like primary polydipsia. So like patients with either like a primary psych disorder that are consuming truly like more than like 14 liters of free water a day, like you can still sort of overwhelm the kidneys and still get a hyponatremia. Or if like you're a marathon runner and you like chug or like sort of blitz the kidneys with too much free water, then it can like effectively excrete quickly enough, you can sort of overcome the kidney's dilutional capabilities and still get like a hyponatremia in that setting. So that's why like there are these really sad situations of like water chugging contests, like leading to patients having seizures and dying. And it's because they are sort of overwhelming the kidney's ability to, in a short term, excrete this much free water. But that's what's happening in sort of like primary polydipsia. Now, the sort of cases that we'll see more often in the hospital are like tea and toast and beer potomania. And this is like like a slightly different variation of the same thing, but here it's actually inadequate solute intake that leads to a narrow, safe, free water intake window. So it's a little bit different. And I like this because there's a joke in nephrology in that a nephrologist looks at a plate of pasta and just sees a cup of water. And that's because like carbohydrates, the way our body breaks them down, doesn't actually lead to any solute for our kidneys to work with. So if you look just the basic cellular respiration and what happens to glucose and other carbs, they essentially get converted into carbon dioxide and water, and there is no solute that's sort of at the end product of that. There's no amino acids, there's no salt, there's nothing in there. And so because of this, like the kidneys like can't really process this in a way that helps them dilute or concentrate their urine. And so like in both tea and toast and beer potomania, this used to like really confuse me. It's not that there's necessarily like a caloric deficit. It's just that the content of the diet is too carbohydrate heavy and there is no solute for the kidneys to work with. So if you think about beer, like the alcohol in beer, like that doesn't end up in any solute for the kidneys to work with. The carbs, like the hops in beer, like that also gets broken down into things that the kidney, no solute for the kidney to work with. And so a patient can be drinking a lot of beer, be getting a lot of calories, but not actually have solute for the kidneys to work with. And similarly, this is like what makes sense for tea and toast, which always confused the hell out of me when I was a medical student. But like these patients, they're not necessarily volume down. It's just that they don't have access to like proteins, like salt in their diet. They're eating very simple carbohydrates at home because oftentimes like bread, things like that are very easy to make. And so because of that, again, we are running into an issue with no solute for the kidney to work with. And so if we do some of the math here, so again, this is sort of like our typical solute load. So going back to our standard American diet, 70 kilogram patient, you end up with about 700 milliosmoles to work with. When you maximally dilute the urine, that gives you about like 14 liters of free water to safely ingest before you become hyponatremic. If we reduced that solute load, so let's say like this is our Abby normal diet. So this is a person who is just drinking beer or like really just subsiding on like tea, toast, carbohydrates that don't give solute. Like now, even if our poor kidneys maximally dilute the urine, we only have 70 milliosmoles of solute to work with, and dividing by our maximally dilute concentration of 50, like all of a sudden, a patient can only safely ingest 1.4 liters of free water, and that is super easy to accidentally go over and ingest more than you should. I'm gonna pause here because I know this is not something that we typically go over, and I think it's important when we're gonna apply it to SIADH in a second. Any questions about this so far? And the other caveat that will come up here, I'll just add, is that, again, we're saying that the kidneys can maximally dilute to about 50 milliosmoles per liter. That's for like healthy functioning kidneys. So tea and toast also becomes more problematic in elderly patients who maybe have a little bit of CKD and say they can't maximally dilute their urine to 50 milliosmoles per liter, and maybe it's 100. That just further narrows this like solute to free water consumption ratio. And it's pretty easy to get sort of consume too much free water that is safe for the solute load that you have given. Cool, and I'll just pause here a second more. But it seems like we're all on board so far, which is good. Blown. Thanks, man. Okay, we're gonna keep going here. So we just reviewed like the ADH independent like causes, but now I want to apply that same physiology and like see how that can help us with SIADH, which again is something that I think is very tricky and we see all the time in the hospital and used to like frustrate the hell out of me like trying to manage. And I was like, why are we giving salt tabs? Like these things like didn't really make sense to me for a while. So like let's say SIADH, because like, well, starting here, like there are formal diagnostic criteria. I will say these are actually all the things that we already talked about like in our algorithm. So it's a hypotonic hyponatremia, so the serum osmoles are low. The serum urine osmolality is high, so ADH is activated. Urine sodium is high, so it's like a normal perfusion state. And then if you notice here, like these supporting diagnostic criteria, these are some of like the pearls that we mentioned earlier. Like the serum uric acid can typically be like surprisingly low. The BUN also can be surprisingly low. And then these other markers that we typically look for renal perfusion indicate that we're not in a low perfusion state in the kidneys. So again, this is sort of like how we diagnose SIADH formally. And then again, I think SIADH can be so frustrating because there are a bajillion things that can cause SIADH. So sometimes it feels like, how are we trying to identify like what is the driver here? And I like this table because it highlights like really any sort of like pulmonary disorder, just like an infection, pneumonia, even if they're sort of like mechanically ventilated, sometimes that can be a trigger for SIADH. If they have asthma and they're in severe asthma exacerbation, that can be there. Nick, yes, exactly. Yeah, and actually Nick called that out because yeah, the failure to improve with normal saline, like that's like the volume challenge that unfortunately all these patients get in the ED. If they don't respond after a volume challenge, we're probably not a hypovolemic patient, and that's why that sort of fits in those criteria for SIADH. But sometimes you don't want to like risk that, so I didn't want to include it there. And then tumors, obviously, like classically we hear about lung cancer, small cell lung cancer in particular. Drugs, like we typically see SSRIs, but as you can see here, like opiates like are a common cause of SIADH. Like essentially so many things that we give hospitalized patients can cause SIADH. Anything going on with the brain, like a new stroke, a new tumor, trauma, like any sort of like cerebral infection can all cause SIADH. And then like most frustrating, like things like nausea or pain can also be a trigger for SIADH. So essentially, anyone who is in the hospital probably has some possible trigger for SIADH, which can make it very challenging to work with, and sort of part of why hyponatremia is frustrating. But I want to go into sort of like how we can use that same physiology of solute to free water, like consumption, to see how we can help these patients with SIADH that are in the hospital. Because again, this is fundamentally, like hyponatremia is fundamentally an issue between solute and free water intake. And now in SIADH, where before in tea and toast, in those conditions, it was an inadequate solute load that was driving the pathophysiology. In this case, it's just a preset urine concentration that's causing all the troubles. So again, this is sort of like our normal situation, like we're getting our normal 700 milliosm solute load. Again, when we can actually dilute our urine, that gives us like a really safe 14 liters of free water that we can take in. But then in SIADH, solute load is probably still the same, but now we have this really high set urine concentration. And so let's say instead of like a maximally dilute urine concentration of 50, like you'll see a urine osms or urine concentration of 500, which is actually pretty reasonable. Like we see that fairly commonly. And then in that setting, despite the normal 700 milliosm solute load, all of a sudden we're back in this situation where these patients can very easily ingest more free water than is safe for them. And again, it's not an issue with solute, it's an issue with the set urine concentration from some inappropriate source of SIADH. And this is why fluid restriction is sort of the cornerstone, and that's why we restrict fluid in these patients, is because we're trying to overcome this abnormally high urine concentration and get them below this free water excretion. Questions about that so far? Because then we're going to sort of use this to see how we can help these patients. Cool. Okay. So again, this is our issue. We have normal solute load, but our urine concentration is too high. But what if we like augment our solute load as a way to help these patients out with their fluid restriction? So let's say we give them, instead of like a diet that's 10 milliosms per kg, all of a sudden now we're giving them a 15 milliosms per kg diet. And so this total solute that we have to work with has gone from 700 to just like 1050. Again, these are just example numbers here. But see how now we've gone from this very sad patient who has to fluid restrict to like 1.4 liters to now all of a sudden like maybe a little bit of a happier patient who has like another 0.7 liters to work with in terms of his like fluid restriction, because fluid restrictions suck, and that's why it's like so hard for patients to maintain them. So augmenting solute load, like this is why we do things like give salt tabs to these patients in the hospital. It's not that somehow the salt getting ingested is like going directly into their serum, because again, like hyponatremia is always an issue with free water. It's that the salt itself is augmenting their daily solute load. And so just a quick plug here. So again, we typically will reach for salt tabs, but there's some actually really fascinating studies on soluble urea. And this is just a masterclass in marketing here too. This is the product Urina, even with like the upward arrow on the sodium and everything. This is soluble urea in packets that patients can take. And for both of these, like just 2 packets of the soluble urea gives you about a like 500 milliosm like extra solute load for patients, and that's equivalent to about like 15 grams of salt tabs. And salt tabs are like can be really hard on the stomach, so like think about soluble urea in these patients. But in either case, like if we're able to make these interventions augment solute load, like all of a sudden, like even if the urine concentration is very high at like 500 milliosms per liter, like this buys patients an additional 1 liter of free water and can really help with their fluid restriction and make just like a very patient-centered sort of intervention that makes it much easier to manage their sodium, like in that setting. Enrico, yes. Oh, actually, Rico, that'd be yes. Very funny. French fries, potato chips, things with salt is also a good intervention. But then don't forget like protein. Like, so again, protein gets broken down to amino acids, urea. That's another way of sort of augmenting solute load in these patients, is making sure they have adequate protein intake. Cool. Just gonna pause again for any questions. Make sure we're on time here. We're doing great. Okay, so like translating this into, yeah, oh yes, Francisco, yes, both like on formulary at Harborview and UW. Thank you for bringing that up. I've used it on 2 patients. One patient loved it and thought it was way better than salt tabs. The other person hated it, and apparently the natural lemon lime flavor is not so natural tasting, and they did not like it. But for the patient who actually could tolerate it, it was really effective. And it's actually this patient that I'm about to sort of like mention here. So like breaking this down into like practical management tips for SIADH, because again, this is something we see all the time, is if you can like address any reversible cause. I'm like pulling up this CT scan. This was a like such a lovely patient that I took care of Harborview and actually in the MICU initially, who had like a pretty diffuse small cell lung cancer. So that's actually, you can see it here in the mediastinum, compressing her right airway. And she had this like really difficult to manage SIADH. Her urine osms were typically kind of set anywhere between like 700 and 900, which, as you can imagine, like gave her a pretty narrow free water like intake window. But like obviously, if you can try to address any reversible cause, if they're on the med, discontinue the med. If they have like a tumor, like try to address the tumor with chemotherapy. See if you can address the underlying cause of the SIADH. Fluid restriction is the cornerstone, because again, they're going to have this really narrow, safe free water intake window. And so restricting fluids is still like what fundamentally you have to do. But you can like practically augment their solute intake. And again, like sodium, like salt tabs, that's the classic, but really think about soluble urea, because well, on my N of 2, it can be well tolerated. And again, can really give them an awesome boost, like a solute boost that can make their free water restriction more manageable. And then protein intake, like actually modifying their diet to, again, try and augment the solute load for their body. And then these are sort of like other 2 that you can consider. I wouldn't really necessarily do these without maybe talking to a nephrology. So Vaptans are like tolvaptan, for example, is like an ADH antagonist. Be careful with Vaptans. They can cause like brisk overcorrection, obviously, because they are just like blocking the cause of the hyponatremia. So if you block it abruptly, people can overcorrect. They're also like oftentimes prohibitively expensive. So they can be something like $3,000 a pill or something obnoxious. So maybe not the best option, but SGLT2s, since they can do everything, it makes sense. Like if you put someone on SGLT2, we're going to lower the glucose threshold. You'll get more glucose as a solute in the urine. And so you're practically giving these patients more solute to work with that way. And they've done some pretty interesting, small, but like promising randomized controlled trials using SGLT2s in this setting. And actually I was on UW wards, and the wonderful Med A team like used this, and actually it seemed like it helped improve like a patient's SIADH in that setting. Questions about any of this? Cool. So we've now reviewed like the ADH independent. We talked a lot about SIADH. We've talked about ways that we can maybe differentiate SIADH from like our classic hypovolemia or heart failure, cirrhosis type pictures. Last sort of question that we really want to address is like, who is at highest risk for overcorrection? Because that, again, that always has to be like our first job, is to make sure that we don't overcorrect these patients with hyponatremia. And obviously we care about this because of osmotic demyelination syndrome or central pontine myelinolysis. And again, this is where the body has gotten used to a low serum tonicity over time. There have been changes in sort of like the organic salt solutes that are naturally produced in neurons. They have gotten used to this low serum tonicity. And so if you rapidly correct it, all of a sudden, like the serum tonicity will be rapidly higher than normal. Free water will rush out of neurons, and we get this demyelination that can have like devastating patient consequences. Interestingly, you can also get this if someone goes from normal sodium to like really brisk like hypernatremia. So again, it sort of gets at the mechanism that this is from free water sort of rapidly leaving these neurons. And because of that, there's like shrinkage of the neurons and you get this demyelination. And so here's just like some MRI images. And again, this can be like a devastating neurological outcome for patients. So like, this is why we really worry about it. This is why we care about it. And so identifying like high like risk patients, the first thing is like severity. So like in particular, like if your hyponatremia is below 110 on admission, like that is a very high risk patient for this to happen. And then sort of conversely, it can actually be like reassuring if the sodium is greater than 120, it's actually like pretty, yeah, it's like incredibly rare for this to happen. So you can, obviously you still want to meet your correction goals, but you don't have to be as concerned as you do for like a really severely hyponatremic when they come in. Chronicity is very important. This almost only happens in chronic hyponatremia. So say you have like a patient who came in from like a water chugging contest and they're seizing, like you can aggressively correct that sodium and not have to worry about that because that was an acute change and the neurons didn't over time have like the ability to adjust to that low serum tonicity, and then this like rapid correction of the serum tonicity leads to all the problems. The neurons in that case are really freaked out about the acute low serum tonicity, and that's what's causing all the symptoms. And sort of conversely, there is some like retrospective studies that asymptomatic patients are maybe even higher risk than symptomatic patients. And that's because like symptoms from hyponatremia are when there is like acute cerebral edema from acutely like lower acute on chronic low serum hypotonicity. So those patients, it's actually probably a little bit safer to kind of rapidly bump them back up like 4 to 6 milliequivalents, because that's probably what their neurons had been used to. And hence, when they dropped even further, all of a sudden they're having symptoms from the cerebral edema. So if you have someone who's coming in with a really low sodium and they are asymptomatic, like that actually might be more concerning than if someone came in and they were seizing in the ED, if that makes sense. And then there are a couple additional risk factors that come up in the literature. When you look at like studies at this, like osmotic demyelination is such a rare event that none of this is like randomized controlled. Like it's all retrospective studies and like the overall quality of evidence is pretty poor. But like things like hypokalemia are associated with like worse outcomes. You can't find like a set cutoff, like is it less than 3? Is it less than 3.5? It's just like in general, hypokalemia might put a patient at higher risk. And then alcohol use and cirrhosis are also like risk factors. And again, like what exactly constitutes like concerning levels of alcohol use isn't exactly clear, but keep this in the back of your mind. Riga, is there an established window where it is considered safe to rapidly? Oh, yeah, if like someone, again, if like there is so for example, like medics at like marathons and where like people maybe just like thinking that they really need to consume free water and they run into this like issue where they rapidly ingest too much free water that the kidneys can safely dilute. Like the medics there, they just carry like bicarb, and like because sodium bicarb is like 6% saline, and they just like slam those patients with bicarb, and they don't have to worry about overcorrecting because if it's really acute, again, you don't really have to worry about osmotic demyelination. In terms of like when someone's coming into the ED and doesn't have that great story for like this was truly just today that the sodium dropped, there's no like clear cutoff. Oh, yeah, Lauren. Yeah, I've heard 48 hours too is like something that you should think about. But again, these events are so rare that it's hard in the literature to like really pull out clear associations. And also it's like sometimes tough to really say like, when did the low sodium start? Because again, most cases of hyponatremia have really vague or asymptomatic presentations. So it's like, it's part of what makes hyponatremia tricky. But again, like these are like risk factors: hypokalemia, alcohol use, cirrhosis, malnutrition also seems to be like a risk factor. And as you can see, this is why like recognizing beer potomania in particular is like really, really important, because not only do they have an ADH independent cause of their hyponatremia, and so the body wants to get rid of free water quickly, they also are at like higher risk for osmotic demyelination syndrome just based on their alcohol use, likely cirrhosis, and sort of like chronic malnutrition and poor health. And then most importantly, this is why we care about the mechanisms for these things. Anna Shama. Yes, and Anna, such a good, like, yeah, that, I have like a brief slide on like ICU level management, but keeping like an amp of sodium bicarb in your back pocket is really, really useful. Because again, like sodium bicarb is 6% like saline, so it's like 6% hypertonic saline essentially. And so that is like a great like way of, if someone like is acutely seizing, you are worried about them, like give them an amp of bicarb, and that usually, if like we know that like hyponatremia is driving the seizures, that can usually like help break recurrent seizures in that setting. But then, yeah, sorry, going back, like, and then we have to identify the states that are at high risk for like rapid correction. And again, ADH independent states, so like primary, well, really tea and toast and beer potomania, because those are more chronic situations. I guess if you have a primary like psych disorder and that's leading to like chronic, really high levels of free water intake, you'd also fall in this category. But those states are really high risk for overcorrecting, because again, the body is trying to get rid of as much free water as it can. And if you give it an appropriate solute load, like the kidneys will take care of it. Sorry, dog barking, he's okay. The kidneys will take care of it and like really briskly excrete free water. And then the other one that I think falls into this category is hypovolemic hyponatremia, because if you correct the hypovolemia, all of a sudden the stimulus, which again was the poor perfusion for the ADH, will go away. And so that also would be high risk for overcorrecting. And so going back to our algorithm, like again, this is sort of where they fall. It's patients with an ADH independent mechanism for their hyponatremia, and then hypovolemia, where the stimulus, the appropriate stimulus, like the hypoperfusion, that was the stimulus for the ADH, but it gets corrected, and now all of a sudden the body is just gonna be like, yeah, let's get our serum tonicity like back to a normal level. And then briefly, just again, because I think the physiology is so interesting here, let's show why like this can happen so briskly in tea and toast and beer potomania. So again, like in these settings, the urine is maximally dilute. So say this poor like elderly patient comes into the ED, it gives a history like, yeah, I'm just like not getting around very well, my diet like isn't that poor. It's really easy to think, oh, this person might be hypovolemic, like let's give them a liter of normal saline as resuscitation. But in a liter of normal saline, that's like 300 milliosms of solute that is suddenly given to this kidney that wants to pee off as much water as it can. And so again, going back to like how much free water will be excreted when we give this kidney like 300 milliosms of solute, doing the math, it's like 6.2 liters of like rapid free water excretion that can occur. And that's again, because the kidneys have been waiting for solute and they really want to get off this free water. And so these patients can really, really rapidly correct their sodium. And so we have to be really respectful and careful of these patients and be good about recognizing this when it comes into the hospital. Cool. Those I think were the, I think I just have one brief slide on like high risk management. And again, this could be an entire talk like on its own, but I'm just going to briefly go through. So this is why, like, again, like if you have a sodium less than 120, like osmotic demyelination is pretty rare if it's above 120, but like less than 120, Nick, that yes, you're prophetic. That's what I'm about to talk about. So yeah, a DDAVP clamp, which Nick is mentioning, is something that can be used for like these high risk patients. But again, if it's less than 120, like you really probably should watch these patients in the ICU at least first. It enables for really like frequent sodium checks. And then also it allows for close urine output monitoring. Because again, like say you had this beer potomania patient, you're giving them solute. If all of a sudden their urine output is really picking up, that's a sign that those kidneys are seeing that extra solute and they might be briskly aquaresing or like excreting off free water, and their sodium might be about to rapidly correct. So what I really like, and Nick just brought up, is for these patients that are really high risk, like say someone is coming in, their sodium's like 112, it looks like beer potomania, and like shoot, like I'm really worried that like we could overshoot this and this would be bad. I really like a DDAVP clamp for these patients in the ICU, and that's where we give them synthetic ADH. It's at 2 micrograms, like you just give it IV every 8 hours. And essentially, it prevents us from overcorrecting. It sort of makes the body a bit of a closed system where we know the kidneys are going to hang on to free water. Then we can give hypertonic saline. And there's actually these formulas out there that you can use on MD Calc that sort of calculates like, what's our goal correction? Okay, like we want to correct 6 milliequivalents in the next 24 hours. Like how much hypertonic saline should we give in that setting? We have the clamp on so that we know that we're not going to overcorrect. And then eventually we can sort of safely take the clamp off. And this is an alternative, like sometimes you'll see D5W being used, but I feel like at least I've used it like twice. So again, my N is 2, but it feels like the DDAVP clamp can be like a safe, effective alternative, and it's becoming more popular. And then this graph here on the left is actually showing a DDAVP clamp, but then it's also highlighting like one other important point where if someone has been like overcorrected, there is still utility in trying to bring them back down to a safe correction range. Because again, this is retrospective studies, but it does seem like it is for osmotic demyelination, it is the average sort of change over 24 hours that really drives the risk for demyelination. And so if someone is briefly overcorrected, like still try to slam them and get them back down either with DDAVP, with D5, get them back to the optimal correction range. The cat isn't necessarily out of the bag like yet. And so still worth like working hard for that. And that's based on also, they've done these like very sad rat studies where they like induced hyponatremia and then they injected like a massive amount of like hypertonic saline into their belly. And then they like either didn't do anything about it or they tried to bring them back down. And the people who spiked but then got brought back down, the rats did okay. So take that for what it's worth. Cool. Questions about any of that? All right. So just reviewing what we talked about, we like went over the framework. I like the ADH-based algorithm because I think it gets at what's going on with the kidneys. We talked more about the physiology of like ADH-independent forms of hyponatremia. We then used that to like see how we can practically manage patients with SIADH. We also sort of viewed some pearls for like distinguishing SIADH from like low perfusion states, which I think is also helpful in the hospital. And then again, high-risk patients, severe, chronic, maybe asymptomatic, and then look for those other things like alcohol use, hypokalemia, cirrhosis, malnutrition as things that can predispose someone to overcorrection. And then again, never miss beer, potomania, or tea and toast, because those are sneaky causes of hyponatremia that are at high risk for overcorrection. Yeah, that's it. Questions like about any of that?
That was awesome, Duncan. Thanks. Any questions? Feel free to put them in the chat. If not, we can kind of get ready for our break here. Let's see.